So this is a 30-year-old male with pleural effusion, and we've seen the specimen from the same patient last week. So he has been diagnosed with mesothelioma, and our previous specimen showed a loss of M tape and Merlin, but retain of BAP1. So let's take a look about the specimen again. So uh, the last week I think we have two different patients with mesothelioma. One with very prominent like cell ball formation. This is the other patient that shows hypercellularity, but the cells show a diffuse pattern. There were only very scant three-dimensional structure, and the structure over here, the nucleus seems to be a little bit smaller than the adjacent larger mesothelial cell. So this looks a little bit different because this looks more bland, but this looks more typical. And so the first clue that we have is hypercellularity. The second clue that we have is that frequent binucleation. Binucleation can be present in the reactive process, but if you see hypercellularity plus binucleation, this gives suspicions for mesothelioma. The other thing is that presence of these organophilic cells, which is also quite uncommon in the specimen, because when we see cell with organophilic cytoplasm, usually we will think about squamous cell carcinoma, but in some patient with mesothelioma, the cell can also show this type of feature. And finally, I would say the nuclear atypia of these mesothelial cells is more prominent than a reactive process. It is very easy that you can see a nucleoli in the cell and with a very bizarre shape. So for example, for this one, this is a cherry red nuclei with an elongated shape, which is also uncommon for the reactive type process. So overall, it has high suspicions for mesothelioma, but because of the cell ball feature is not very prominent, without any ancillary test, we can probably only suggest or suspect that it is a mesothelioma, but we would definitely need some more ancillary tests to confirm the diagnosis. So this is the second specimen. So we've already confirmed the loss of tumor suppressor gene, tumor suppressor protein in the prior specimen. So this one is a mesothelioma. So this is the cell block. Again, we see hypercellular, but not so prominent like three-dimensional cell ball architecture. But these cell block specimen will be good for the ancillary test. So because we already done the ancillary test, we will just call these positive, compatible with mesothelioma. The second specimen is from ascites of a patient who is 77-year-old, a female. She had a past history of pancreas adenocarcinoma. So this is the ascites specimen. In this specimen, we find some like a configuration artifact that the cells are all concentrated only at the periphery of this circle. And the background material shows dense proteinaceous material. So in this type of specimens, sometimes the cell will show more prominent artifact, and it is not easy to identify lesions in such condition. But here we see there is a cluster of cells with a strange, like a pleomorphic nucleus, and with very strange shape, and it seems to be form a cluster, a tight cluster. So due to the history of pancreas cancer, I think the specimen is suspicious for adenocarcinoma. So I would say it is not easy. So the screener has started a couple, but not as prominent as the last one. But here is also a typical cell cluster. In the cell block preparation, I think it's easier for us to identify three-dimensional like cell cluster. And here we see a cluster more glandular feature with traction artifact over here. Right adjacent to it, this is also a typical cells and with traction artifact in three-dimensional cluster and with glandular feature. So usually for the pancreatic adenocarcinoma, the nuclear DPR can be quite bland. So I think the case definitely has some atypical cells. It is not so many, it is very scattered. However, these type of features are compatible with adenocarcinoma. So let's do adenocarcinoma marker. So we will do MOC 31. I find that Claudin 4 usually stand much weaker than MOC 31. So I start to do MOC 31 again instead of Claudin 4, because usually Claudin 4 has a very faint staining, sometimes very difficult to interpret. So I think this is positive for adenocarcinoma just because of the low tumor component. We would just check it with the ancillary marker for the confirmation. So let's move to the FNA specimen. This is the EUS guided FNA. So we're starting to perform the liquid-based cytology on this type of specimen. So here you can see this is more like a benign ductal cells and with beautiful luminal border. The nucleus are small, regular, and with a honeycombing arrangement. On the other hand, here there were a few very scattered, larger cellular fragments with more enlarged nuclei. However, for this cluster, we didn't see very prominent nucleoli. We only see like enlarged nucleus of the cell in cluster in glandular shape. Here is a cell with a more eccentric nucleus and a little bit of vacuole in the cytoplasm. However, the overall feature, I would say, is only suspicious for adenocarcinoma, but not definite. And because of this low cellularity, I think the most like a convincing area for adeno would be probably over here. So we have more vacuolation in the cytoplasm. The nucleus seems to be very disorganized and overlapping. So I think the specimen is suspicious for adenocarcinoma. Here, we see very scant necrotic pattern over here. Okay. The biopsy, the concurrent biopsy specimen already diagnosed with adenocarcinoma. But in these cytology specimens, I find that the cellularity is not enough, and the nuclear feature is not unequivocal. So I decided just to call these suspicious for adenocarcinoma. But overall, I think the pattern is highly suspicious for adenocarcinoma. If we have more cells, so this one I call it suspicious. So the next specimen is a patient with a past history of lung cancer, and this is a rib fine needle aspiration. So it is inside the bone. So when we see the bone aspiration, usually we would like to see marrow component. However, in this specimen, you only see is blood and these tight cluster forming a glandular structure. Again, the cellularity is not very high. However, because it is inside the bone, I think it's diagnostic for adenocarcinoma metastasis. So we call it positive. And because the patient had a past history of lung cancer, and it is compatible with the lung. So this is the direct smear. We see much more like carcinoma adenocomponent. So these cluster, I would say, is quite definite for adenocarcinoma because you can see prominent like polymorphism overlapping disorganized glandular feature. So this is positive for adenocarcinoma. The other next specimen is also a bone aspiration. It is from the vertebral spine. It's from the T9 segment. The patient had a past history of posterior pharyngeal squamous cell carcinoma. So in the background, we can see like cellular debris forming a polygonal shape and without the nuclear. So it seems to be like necrosis, and with a squamous cell, like a shadow type of like shadow type of the cellular component. So this is quite common for squamous cell carcinoma. When we want to diagnose squamous cell carcinoma, we want to see cells with unequivocal hyperchromasia, as well as high NC ratio and coarse chromatin pattern. So for this case, I think this is keratinized, necrotic keratinized cells, and this is more basal, parabasal type of cancer cell. So the specimen is diagnostic for squamous cell carcinoma. So it is compatible with metastatic oropharyngeal cancer to the spine. So the next specimen is from a 59-year-old female who presented with a neck mass in the midline neck. And under the sonography, the mass shows cystic feature. So we had a cystic lesion in the midline of anterior neck. In the aspiration, we can see there were definitely cystic component with a lot of histiocytes and some granular debris, cystic debris in the background. What is unusual for these specimen is that we do identify a few ciliated epithelium, toe columnar ciliated. So these type of epithelium looks like respiratory type epithelium. So usually for this type of neck mass with cystic change, first thing that we want to know is the location, if it's in the midline or if it's in the lateral neck. For the midline, especially the area between the hyoid bone and the thyroid, we will usually like suggest that it can be a thyroglossal duct cyst. If it's in the lateral neck, it's possibly a brachial cleft cyst. Both cysts can compose of respiratory type of epithelium. So these specimens that we do see, this is not common. We rarely see. Usually, we will only see the cystic fluid, but in this specimen, they do sample the ciliated respiratory epithelium. So this is compatible with thyroglossal duct cyst. The next specimen is from a 67-year-old female with a right neck mass. So usually when we receive the requisition sheet, sometimes they only write neck mass. So then there were so many different possibilities of a neck mass. It can be coming from a lymph node, from thyroid, from salivary gland, from soft tissue. And it can be solid and it can also be cystic. So you definitely need to check more details if the neck mass is the only information that we have. So for this specimen, we identify cellular fragment, which is composed of mostly spindle cells with dense extracellular material. So when we go on a little bit higher power, the cell had these sausage shape, some with more like a curved shape. Somebody would say, oh, it's like a coma. And embedding in this extracellular material. So the cytomorphology is mostly compatible with schwannoma, and which is also one of the most common soft tissue tumor that we will encounter in the fine needle aspiration. So if we check the direct smear, which is much more easy to see the nuclear feature. So again, we have these sausage shape, some with palisading, like in a palisading pattern. And if we check loose end, you can see the extracellular material, which is more commonly to have this magenta color. So the specimen seems to be from a soft tissue tumor with mostly spindle cells, and it is compatible with a schwannoma. So this is a case of schwannoma. So the next specimen is from a patient with a thyroid nodule. So this is from the thyroid. On low power, you can see there are some background like bleeding. So we see RBC, and there are small like clusters of larger like cells throughout the entire specimen. In the background, we didn't see much colloid. On higher power, these cells have enlarged nucleus and distinct nuclei, and also quite abundant like granular cyanophilic cytoplasm. So these cell components are actually oncocyte or Herzl cells. So the specimen is composed mostly Herzl cells. For the Herzl cells, sometimes they will have some nuclear atypia and some polymorphism. So based on this morphology and without the colloid, I think the specimen that we see is suspicious for a Herzl cell tumor. However, if we go back to the clinical note, the patient has been suffered for hypothyroidism for many years. So she has under thyroxine, like a supplement, for many years. The most common cause for hypothyroidism is actually Hashimoto thyroiditis. So for the Hashimoto thyroiditis, occasionally you will have some oncocytic or Herzl cell nodule, but it's not necessarily to be a tumor, follicular tumor. So overall, I think it is okay that we call this specimen just AUS with Herzl cell type of TPR. And in the background, you can also see some plasma cells, some lymphocytes. So sometimes in the Hashimoto thyroiditis, the nodular lesion can be very prominent, and it can cause it can mimic a oncocytic tumor, and it is very difficult to differentiate just with cytology, because you definitely see more Herzl cell cluster, and these features are similar to what you can see in the Herzl cell neoplasm. However, in the background, you also see quite a lot of plasma cell lymphocytes. So I feel it's better that we don't call it tumor right away, but we use the AUS category. So let's move to pap smear. So this specimen is from an 85-year-old female. So she is quite old, and she presents to us with vagina bleeding. So for this specimen, definitely it shows a feature of atrophy. And because clinically she developed vagina bleeding, it is highly likely that we will see some endometrial debris. So this is the feature of endometrial debris. Usually in the conventional smear, it goes on the same direction, smearing direction, and you can find some granular debris admixed with neutrophil, as well as some plasmacytoid cells, which is most likely histiocytoid plasmacytoid cells, which is most likely a stromal component of endometrium. So in such specimen, usually we will go through the debris area to see if there is any atypical glandular cells. So for this specimen, I think I didn't see any atypical glandular cell, but only the endometrial debris. So there were a few clusters highlighted by our screener, but these very degenerative, very small cells also looks like stromal cells. So stromal cells. We actually didn't see any atypical glandular cell. And this one also, it's very tight. And the small high NC ratio like a feature, which is compatible with a cluster of stromal cell, not a glandular cell. So for this specimen, we cannot call it a typical glandular cell because we didn't see any atypical glandular cell. What we only see is the stromal component as well as the debris. So we call the pap smear atrophy, and we address that were presence of endometrial debris. And this is enough for the clinician because they already know the patient like presented with vaginal bleeding. So the next thing they need to do is to check firstly by the sono to see the endometrial condition and maybe followed with DNC. So the last specimen is also a pap smear. And this is from the patient of 60 something year old. So also it shows atrophy pattern in the background. So atrophy sometimes very very difficult because it can show sometimes like abruptly enlarged cells, sometimes with hyperchromasia. So it is quite difficult to make judgment if these are within the spectrum of atrophy or is starting to develop some dysplastic lesion. I think in this particular specimen, these enlarged cells is a little bit too much for the atrophy. It shows hyperchromasia and it shows clearly a bit more coarse chromatin pattern. And these type of cells is actually not uncommon to see throughout the entire specimen. So in this situation, I would call the case as a typical squamous cell, ascus. So I think this is when we see a specimen of atrophy, if it only shows enlarged cells, but with a more smashed chromatin pattern, sometimes we won't be too worried about this. However, because of this specimen, the enlarged cell is more prominent and the chromatin pattern is more hyperchromatic and with a coarse chromatin. So I think it's reasonable to call it a typical squamous cell, and the clinician can make further evaluation for the condition. So we call this ascus. Okay, so that's it for today.
Thank you.